and welcome back. Today we're going to look at our traction device. So our traction device is for a midshaft femur fracture. Where's a midshaft femur fracture? That's going to be on the femur, about a palm's length above the knee, and about, Nathan, can you show me a palm's width below where the femur enters the pelvis? For our midshaft femur fracture, a lot of times we'll notice that the leg is shortened or rotated. We'll notice that in comparison to the good leg. First thing we're going to do is we're going to have our partner Nathan hold manual stabilization of the injured extremity. So he wants to hold above and below the break. When we have a femur that breaks, we have a top piece and a bottom piece, and that major muscle pulls them together and overlaps. What we want to do is make sure that we don't have any unnecessary movement to those two injured pieces. So if we have to move them for a device where we have to pull the leg, we're going to pull that manual traction and hold it until we have a device to continue holding that traction. A device such as the Sager or KTD, we can leave the leg in place, have our partner hold our manual stabilization, apply the device, and then pull our traction. So today we're going to show you the Sager. The Sager looks kind of like a crutch. It's going to have a piece that's going to go high and tight into the patient's groin, and that's going to be the anatomical feature that keeps our device from moving up. And then on the other end is going to extend down with an ankle hitch. Before we put on our device, we're going to check our CMS. We're going to compare our CMS, our pulse of the injured extremity to the non-injured extremity. Right now I have equal bilateral pulses. I want to check my efferent motor neurons by having my patient wiggle their toes. Chandler, can you wiggle your toes? And then check my afferent or sensory by having them tell me which toe I'm touching. Chandler, can you tell which toe I'm touching?
Big toe.
And can you tell me which toe I'm touching?
Little toe.
When we put on a traction device, we want to make sure that we have no pelvis involvement, because pelvis injury is going to be a contraindication. No knee involvement, tibia involvement, or ankle involvement. All right. Chandler, this device is going to go high and tight in your groin. If you have anything you need to move, adjust yourself now. Okay? Talking to our patient to move their parts out of the way is important. This is going to be our ischial strap. Our ischial strap is designed just to hold the device to the leg. We want to make sure that our buckle is on top of the leg and not hidden under the leg so that we can tighten the buckle. Then we're going to take our ankle hitch, slide that underneath the patient's ankle. We're going to position that just above the malleolus and secure that tightly around the patient's ankle. Now that we have our device high and tight in the patient's groin and our ankle hitch secure, we'll put one hand on the upper shaft, one hand on the lower, and pull them apart. That's going to pull our traction. We want to pull no more than 15 pounds or 10% of our patient's body weight. Chandler is more than 150 pounds, so I'm just going to stop at 15. If we have a device that doesn't have a scale, we can pull until our patient feels relief or until the injured extremity matches the good extremity. Once we have our device in place and traction pulled, we're going to secure our device. We can use the the space underneath the knee to slide our securing strap. Going to secure that to the thigh. Now Nathan can stop holding stabilization. And using the knee, we're going to slide that under and floss it down to the calf and secure the device to the leg. Then we're going to go ahead and recheck our CMS. I'm checking the CMS on this leg, but also comparing it to the good leg. Channeling, can you wiggle your toes? Can you tell me which toe I'm touching? Big toe. Can you tell me which toe I'm touching? Little toe. Now we're going to take our patient, move him to the backboard, secure our patient to the backboard, also making sure we secure the hip and device to the board, and rapidly transport our patient.